Good evening, everyone, and welcome to SWESEM Learning. My name is Mohamed Aburegev, together with my fellows, on the behalf of the Swedish Society of Emergency Medicine Learning Platform, welcome you all tonight to our webinar. Just to remind you, SWESEM Learning was created with simple but important vision to bring together clinicians who are deeply passionate about resuscitation and acute care, to share the practical knowledge that changed the bedside practice, and to connect the Swedish emergency physicians with the global resuscitation community. Because emergency medicine evolves fast when we learn not only from our ED, but from each other, cross systems, and across countries. So, in emergency department, regardless if you are the person who are intubating or you are just assisting in intubation, the critically ill patient has been fundamentally different context than that in the elective settings. Our patients are not only physiologically not optimized, they are hypoxemic, they are shocked, they are acidotic, exhausted, or agitated. So their oxygen reserve is already depleted before when even we begin with them. So why desaturation during emergency airway management remain one of the most dangerous and common complications in the resuscitation practice. To be honest, when me and my colleague prepare for tonight's session, we realized that introducing our speaker is both easy and difficult at the same time. Easy because he is so well known to everyone involved in the resuscitation, but it is very difficult for us because his impact in our field is so large that it's very hard to summarize in a few sentences. So for me personally, just to be honest and say, Dr. Scott Weingart has been one of my greatest inspiration in resuscitation field. I think it's by far now almost everyone who's passionate about resus has at some point listened to at least one or two MCRET podcasts. So just to keep a few points in mind, by the end of the webinar, we should learn how we preoxygenate, how we prevent deoxygenation, and how we reoxygenate when things do not go as planned. Thank you very much. Dr. Rasmus, the screen is yours.
Thanks. Just a couple of housekeeping rules. We have a chat. You're very welcome to put any questions in there at any time. We'll try to just wait them in as they come. You're also perfectly fine, just if you want to ask your question by yourself, unmute yourself, raise your hand first and get the words, and then unmute and you're able to speak directly to us. We'll just try to keep it interactive this time, right? So yeah, that's it. Mohammed.
Yes, Dr. Weingart, the screen is yours.
All right. What an honor. So wonderful to be speaking to you all, and especially on a topic that I love. I mean, this is the stuff I salivate over, is the physiology of the peri-intubation and all of the things that go into safely putting a tube in a very sick patient. So I'm really lucky to get to speak to you today. Mohammed, thank you for setting this all up. Thank you for your interaction. You've been a joy to deal with over these past few weeks. All right, let's see if I could get my slides up. And here we go. And as Rasmus said, feel free to stop at any point during this discussion and ask questions. I actually enjoy making this a conversation more than me just talking at you. So we'll talk about preoxygenation, but I know that in the context of where you're at, in many cases, you're not going to be putting in the actual tube. Now, hopefully that will change over the next 2, 3, 4 years. That's going to be different. But for now, you're calling someone from anesthesia. Don't abdicate responsibility for the physiology of that, even though someone else might be doing the actual laryngoscopy. You, it may turn out, may have more cutting edge knowledge on how to keep that patient alive during the intubation. And now it becomes a real team sport where they might be providing the actual physical skills of laryngoscopy and tube placement, but you could be providing the augmentation of the patient's hemodynamics, the provision of fantastic oxygenation techniques so that the patient does not succumb to the very real possibility of peri-intubation, decompensation, or cardiac arrest. So that's why I felt this was relevant, even though you might not be doing the physical act of intubation. Now, for years, I mean, since the very beginning of my career, I've been talking about the laryngoscope as a murder weapon. That so often, and I, from the very beginning, was providing quality assurance for airway management. And I would see time and time again patients, they were alive before the tube was placed in, and then they were dead around the intubation, and it was blamed on the patient. They were really sick, they were very unstable, and time again, the patient was being blamed. And yes, the patient's sick, but the thing is, decompensation around intubation is predictable and preventable. You bear the responsibility. You have to keep that patient safe. So every time you're being given a laryngoscope, or you're calling someone to put a laryngoscope in that patient's mouth, essentially you're being given a license to kill. And how you go about using that awesome responsibility depends on how much you care about your practice and your patients. So take home, if nothing else, that peri-intubation deaths are preventable. So how are we doing preoxygenation and support during the intubation in 2026? Well, if you ask me what people were doing in 2025, or at least the beginning of that year, almost every emergency department was placing the patient on a 100% non-rebreather, which is a device that doesn't actually exist, right? What they're really talking about is this device. It's a reservoir face mask. And the problem with this device is it has holes, right? And so if you put that device at 15 liters per minute with its holes, you might think the patient's getting a good provision of oxygen, but they're really not. That reservoir face mask provides 60% FiO2 at 15 liters per minute. 60% is nowhere near enough to give your patient the buffer of alveoli filled with oxygen. That's what you're trying to do in the preoxygenation state, is you're trying to denitrogenate the alveoli, meaning you're trying to replace all of the nitrogen that is a large 79% component of room air with oxygen, so that the patient has this huge bag of oxygen to be used during the apneic period after pushing a muscle relaxant, as well as during the laryngoscopy attempts itself. And we kind of have a delusion as to how long laryngoscopy takes. If I asked you Mohammed, how long does it take you to intubate?
Yeah, it's a very difficult question.
Yeah, well, that's the right answer, because most people would say it takes me 20 seconds, 30 seconds at the utmost. But when we time it, and we videotape all of our laryngoscopies, it takes about 60 to 90 seconds in the hands of a good person. Like, that's not a failure. Like, failure would be like 4 minutes, right? Like, that's a problem. 90 seconds is well within the standard time it takes. So we're talking about 2.5 minutes sometimes that the patient has to be apneic. And so what you want is this big alveolar reservoir so that the patient won't desaturate, right? Now, if you put that reservoir face mask, that quote-unquote non-rebreather, on flush rate oxygen, it's kind of a different story. Now, what do I mean by flush rate? Flush rate in the States, at least, is our flow meters, most of them, the standard ones in every emergency department, they're calibrated to 15 liters per minute. But if you keep turning the dial counterclockwise, it goes up to between 55 and 75 liters per minute. And as you keep turning it, it sounds louder and louder. It sounds like a jet engine. And if you put a patient on greater than 50 liters, 50 liters, then they get very close to what you want, which is 95% FiO2. So all of a sudden, the reservoir face mask does become a very reasonable denitrogenation device. All right. Now, in Australia, their flow meters, when you open them up as wide as they go, only go to 20. That's not nearly enough. That's going to provide, I don't know, like 65, something like that. Nowhere near what you need in order to get the full denitrogenation. Do you guys know what it is in your neck of the woods? How can you open that flow meter a ton and really make it loud, or does it just get a little bit louder than the 15?
My shop,
It gets really loud.
Okay.
25, and then the other one that you can just
all right.
turn.
So Rasmus is in Iceland, so we're hearing they have the limited ones, and it sounds like the run-of-the-mill ones is that most people in the audience have will go up to flush rate. So that's great. Now, if you are in a place where it goes up to 20 or 25, you could still augment that reservoir face mask by adding in a nasal cannula underneath. You put that at 15, you put the non-rebreather at 20, 25, you get something reasonably close to okay. And so that's another means of augmentation. Now, the problem is that even using that device correctly can denitrogenate well, but the patient is still going to have derecruited alveoli. Their alveoli, because they're sick, right? Like this, everything we're saying in this lecture is about critically ill patients, patients in the ED, patients in the ICU, in contradistinction to elective operating room cases. See, elective operating room cases, if you put them on a properly, a high flow rate non-rebreather mask, they could last 6-7 minutes. That was Benyamov's data, because they have normal lungs. Obviously, if you take a sick patient to the OR for an emergency case, it's a different story. But the elective cases, their lungs are not sick. ED patients have sick lungs. So just denitrogenating is not enough. It's better than not doing it, but it's not enough to prevent hypoxemia. Let's go through just a little bit of our basic medical school physiology just for 2 seconds to remember what causes hypoxemia, right? These are the 5 things we learned: hypoventilation, inadequate actual oxygen in the supply of what gas they're breathing, VQ mismatching, diffusion abnormality, and shunt. You don't need to worry about any of those. I said them, forget them all, except one. The only one that matters is shunt, because after you provide 40% or greater of FiO2, all of them disappear. They're all oxygen responsive. The only one that's not is shunt. Shunt's the only one that matters. So, shunt is what we need to understand in emergency medicine, right? We should give it respect. Like, shunt is what kills our patients in the peri-intubation. So remember what shunt is. And we're talking about physiologic shunt. We're not talking about a hole in the patient's heart. Physiologic shunt is we have a number of alveoli that for whatever reason can't participate in gas exchange. They could be atelectatic, completely crushed down. They could have fluid, pus, blood, whatever in them. And as a result, the venous blood goes in at 70%. It passes the alveoli that can't participate in gas exchange. It goes out at 70%. It doesn't matter how high the FiO2 is. If you have shunted alveoli, the patient is predisposed to rapid desaturation during the peri-intubation. So how do you solve shunt? You solve shunt by increasing mean airway pressure. And I've been saying this for, upwards of 20 years, right? I've been saying that we cannot improve mean airway pressure with non-rebreather masks. We can't improve mean airway pressure with bag valve masks in their standard form. And what we need to do to keep these patients safe is increase mean airway pressure. What we need is CPAP. We need CPAP as not just, a response to patients with COPD or pulmonary edema. We need CPAP as a response to the fact that critically ill patients, when being intubated, have shunt already and develop shunt during what we do to the patient, which is once we give the patient muscle relaxants, their shunt gets worse, or if it wasn't there, it develops. So they're going to have pre-existing shunt. They're going to have shunt that we actually give to the patient as a result of what we do. And then if we don't get the first intubation and we have to intubate on the second or third try, there's even more shunt. So shunt kills. Shunt is hypoxemia. Hypoxemia equals hemodynamic collapse, oxygenation collapse. So we need to stave that off. Now, for about 18 of those 20 years, I've been saying what we should be doing is putting the patient on the ventilator for preoxygenation. And it works wonderfully. The patient gets perfect FiO2. You could dial in whatever mean airway pressure you want. And I've been saying this. And no one really took it up because there was no evidence really to support it. There was like scatterings of little studies. But it's hard to convince people of things when you don't have a great study. Well, now we have a great study, right? We have Preoxy. Preoxy was a wonderfully wrought study by the folks at Hennepin and a bunch of other centers in the ED and ICU. And what they discovered is that the comparison group was just do whatever you do normally for intubation, with one tiny change is they educated them to do the flush rate oxygen on their non-rebreathers. We don't know how many people actually did it, but they told them to do it. That was the standard care group. And the intervention group was putting the patient on either a ventilator attached to a non-invasive mask or a CPAP machine, a non-invasive machine attached to a non-invasive mask. and putting the patient on some degree of increased mean airway pressure. And when you looked at the results, hypoxemia, less than 85%, that's important, right, was halved. It went from 18 to 9, right? Now, the one that's really important, the hypoxemia less than 80%, we call that critical desaturation. That's when patients start having risk of hemodynamic and oxygenation collapse during the intubation. That one was really important. Again, halved, 13 to 6, right? Cardiac arrest was cut down to a fifth of the cases, 1% to 0.2%. And then the fear people had, well, they're going to have an increased aspiration risk because you're going to be insufflating the stomach, didn't happen. There was no significant difference. And in fact, the point estimate was higher in the standard care group, which is good because otherwise they'd argue, well, it didn't reach statistical significance, but there was a trend towards it. No, there wasn't even a trend towards it. So it's safe, it works. Now, this is the real clincher. If you look at patients who supposedly had great lungs, they were being intubated for reasons other than pulmonary. Maybe they were being intubated for airway protection, or they were obtunded as the course of sepsis or what have you, but good lungs. So they were satting 100% on room air in the hour before intubation. They also had the same benefit of markedly decreased hypoxemia. So everyone in this study, at least if you believe the data, should have gotten the treatment arm because it had significant benefits in all patients. So what did they actually do by sticking the patient on a ventilator or non-invasive machine? Well, they had perfect FiO2, right? The ventilator or non-invasive machine's perfect at delivering 100% FiO2 or near to it. They were giving them PEEP in the preox. They put them on at least 5 of PEEP. They were getting inspiratory augmentation during preoxygenation. They had put them on 5 of pressure support or non-invasive settings of 10/5, which is the same thing as 5 of pressure support and 5 of PEEP. Did that one matter? I don't think it mattered at all. And when I talked to the study authors about it, I interviewed them on MCRIT, they agreed. That doesn't matter. The reason they did it is because that way when the patient became apneic, they didn't have to change the ventilator settings. It was going to be giving them breaths as soon as the patient became apneic. So that one I don't even think matters. They were receiving breaths during apnea. We have evidence from this both from Preoxy and a prior trial called Prevent that the patients do better if you bag them during the apneic period, which a lot of your anesthesiologists may be doing, they may not be doing, depending, because when we originally were taught RSI, we were told you're not allowed to do that. But Prevent and Preoxy have proven it's safe, and you absolutely should. You should not leave the patient apneic. And then they were providing PEEP during the apneic period. So they were continuing that increased mean airway pressure during the apneic period, where I think it matters most because patients will get shunt in the apneic period after a muscle relaxant, even if they didn't have it beforehand. So we've gone through all these. High FiO2 preox, it's necessary but insufficient. PEEP, absolutely essential to stave off shunt. Inspiratory pressure, not that important during the preox. Apneic breaths during the apneic period, incredibly important. Apneic PEEP, incredibly important. And I add in one more thing that they didn't address in Preoxy, but I think is an important thing, which is apneic oxygenation during the laryngoscopy. Now, apneic oxygenation, which is the fact that even when the patient's not breathing, if you wash their oropharynx with high FiO2, patients will continue to oxygenate just by bulk movement of those oxygen molecules down the trachea. It works perfectly in the operating room. Did not seem to work very well in the ED or ICU. The data goes back and forth. My contention is the reason it doesn't work very well in those studies is they were not getting PEEP or mean airway pressure during their apneic period, and therefore they develop shunt. And once you develop shunt, APOX can't work because you're going to continue to desaturate no matter how much oxygen is taken up by the alveoli that aren't shunted. So my contention, and I don't have proof yet, hopefully the follow-up studies will bear this out, is if you're doing a preoxy protocol, apneic oxygenation will suddenly work and is beneficial to add in to the mix. All right, so I told you the settings they had in preoxy, non-invasive machine or vent, FiO2 100%, pressure support of 5, PEEP of 5, 10 breaths per minute, and they continued that during apnea. This is a sea change in how to manage patients in the peri-intubation. If anesthesia comes down and they're not going to do this, you should do this. You should have done it even before you called anesthesia down, because many times what happens is you're ready to intubate, you're going to be doing the real brunt of the preoxygenation. And then when anesthesia gets there, they essentially just want to stick the tube in. So if they arrive and you say, I've had my patient on a non-invasive or vent or easier ways than I'm going to show you for the past 4 minutes, they could just now take that mask off and intubate after pushing their meds versus now having to do a preoxygenation while they arrive. And the odds are, if they're not up to date on the literature, your preoxygenation is going to be better than what they would have provided. Because chances are, if you just leave them to their own devices, what I see anesthesia in the United States do is they just will take off whatever's on the patient, put a BVM over their face with no PEEP valve. And like I said, that's going to provide high FiO2, and it's going to do nothing to increase mean airway pressure. So why aren't docs doing it? In the States, even though the study's published, docs are still not doing it. Now, part of that's just the uptake timing. It takes about 10 years before social media for a new study to actually ramify on clinical practice across the board. Now, hopefully social media, because it's just more rapid, it's more potent, has cut down on that implementation time. But I don't know to how much. But the other reason that we can affect is even though it seems a relatively light ask to place a patient on a non-invasive machine or a ventilator for the preoxygenation, in reality, it's kind of a pain in the butt, right? Unless you have ventilators or non-invasive machines and masks already in your department, sitting in every resus bay that you intubate in, it's a real difficulty oftentimes. You have to call respiratory. A lot of the intubations, you can't wait for respiratory to come, and they have to bring a machine, they have to set up a machine. It doesn't happen. And a lot of the times people are just, we're just going to intubate the old way. We're just going to put them on the BVM and do it. So there needs to be an easier way if we want uptake of this. Well, I have one. I'm not going to state the problem and not give you a solution. So let's make this easy. All right. So this is lazy positive pressure preoxygenation, but it works just as well. All right. So I'm going to give you 3 risk stratifications, and we'll make it as easy as possible for each of those. Don't worry about this complication of this this chart. I'm going to go through it step by step. I just want to have the overall idea in front of you. We're going to separate patients out to low risk, moderate risk, and high risk. All right, now low risk, these are patients who are satting well, ideally 100% before intubation. And these patients generally don't have lung pathology. And so all we want to do on these patients is keep them in the good state they're in and not let the peri-intubation mess them up. So I'm going to break this down into preparatory phase, which is, the getting ready, the head of the bed phase, which I'll explain momentarily, the apneic phase after you push your meds, and then the laryngoscopy phase. So the preparatory phase, on these patients, I think you're okay with the old school stuff, as long as it provides high FiO2. So in these patients, a non-rebreather mask, a reservoir face mask at flush rate, or if you don't have flush rate greater than 50 liters, a nasal cannula plus reservoir face mask, both of those at 20, 15 or 20. Or if you want, you could, even for these patients, put them on a non-invasive mask and a ventilator or a non-invasive machine, or you could put them on true lazy person positive pressure preox setup, which I will show you in a second. For now, just put a pin in that. So we're going to leave them on that for 2 to 3 minutes, all right? And that's going to start the job of denitrogenation. It's not going to augment their mean airway pressure. Then we're going to come to the head of the bed. This means we have all of our intubation supplies now set up. We have our meds ready. Everyone in the room it's go time. We're not going to push the meds at this point. We're going to go to the head of the bed. And this is what I do anyway, even before preoxy, is I always had this head of the bed phase. And what would happen at the head of the bed phase is we'd run our intubation checklist. This is the time for that. Because now ostensibly everything's ready to go. This is the time to actually make sure everything's ready to go. And oftentimes in an inexperienced system, you'll find, all right, I was about to push the meds, and then you run the checklist and you find 4 things that were imperative were forgotten. So that's what this head of the bed phase is. During this head of the bed phase, I will take off the non-rebreather mask and I will put on a BVM with a PEEP valve. This is key. Without a PEEP valve, BVM is not going to be sufficient for mean airway pressure increase. And in many of them, they don't have the right valve structure. The patient can't even spontaneously breathe 100% FiO2 through it. They're breathing room air. If you put a PEEP valve on any BVM, even at 0, it fixes their exhalatory port and makes it one way. So it in both respects, both mean airway pressure and providing high FiO2, you really want a PEEP valve, to the point where all of our rooms for resus already have the PEEP valve placed on the BVM by our clinical assistants before we even enter that room. So you'll never enter one of our resus bays that doesn't have a BVM hooked up to oxygen with a PEEP valve already on it. You want a nasal cannula underneath, which we'll talk about why in a second. And then all you do is you hold a 2-hand mask seal over that BVM mask, hopefully with your thumbs facing the patient's feet, because that's the proper way to hold a mask. And you let them breathe through the BVM. You don't squeeze it. There's no need for that. It just is going to piss the patient off. You just let them breathe through that BVM with a PEEP valve, 2-hand mask seal with a nasal cannula underneath. The nasal cannula will not affect the mask seal. It's absolutely fine. You put that PEEP valve at 5 or 10. 10 is my preference for every patient. I have some studies to back that up. I think preoxy went a little too low. And you let them breathe that for 60 seconds. It's going to continue their denitrogenation, but it's also going to augment. If there is any shunt, they're now breathing increased mean airway pressure. During the apneic phase, you push the meds, you hold that BVM with a 2-hand mask seal, and you have a buddy gently squeeze that BVM, 8 to 10 times during that 45 to 60 seconds. Then during the laryngoscopy phase, you leave the nasal cannula on. That's going to provide the apneic oxygenation. All right? So that's your low-risk patient. So flush rate, non-rebreather, plus nasal cannula while gathering gear. Come to the head of the bed. You put them on a device for the patient to breathe that has PEEP. There it is. There's your lazy person's preox setup. BVM, PEEP valve, end-tidal CO2, nasal cannula underneath. Now, even better, this is the true laziest of lazy persons, positive pressure preox. Just stock the non-invasive masks in your department. Just demand a medium and a large size non-invasive mask stocked in your department. Then all of a sudden you don't even have to hold the mask. Then all of a sudden you never have to put them on the non-rebreather, because what you do, and this is the laziest of lazy, and it works just as well as preoxy, is you put the non-invasive mask on and you attach with a nasal cannula underneath, and you attach the BVM with the PEEP valve to the non-invasive mask. All of a sudden now, the patient is breathing essentially the same thing they would be breathing on a ventilator or a non-invasive machine without having to get any machinery. It's perfect. The only thing you have to be careful of is you need non-invasive masks that are completely sealed. Some of them, the non-invasive mask has a exhalatory port on it. And if that's the case, this is not going to work. So you want the ones that are completely sealed. Those are the ones you need to use with a ventilator anyway. So it's not like anything magical. It's the same one you would need for preoxy. So you just stock the right mask in your department, and all of a sudden you don't have to hold a 2-hand mask seal. You never have to use the non-rebreather. From the get-go, you just put them on this lazy person's positive pressure preox, and you're going to be totally in keeping with the preoxy studies results. All right, so nasal cannula, 10 to 20 liters per minute, BVM with a PEEP valve, and a non-invasive mask, ultimate lazy positive pressure preox. All right, and then you just leave it on, and then you bag them during the apneic period. You want end-tidal CO2 for every breath you deliver in an emergency department, whether it comes from a BVM, a ventilator, non-invasive, etc. Put end-tidal CO2 on, otherwise you don't know if they're going in. And then that nasal cannula is there for preoxygenation. All right, moderate risk. These are the patients who are desaturating, but you're able to maintain them, and they only have one of the physiologic disruptions. So they might just have oxygenation problems. They don't have oxygenation plus hemodynamic or acidosis or right heart failure. Just one. So patient, they're desaturating. You might have temporized that desaturation with non-invasive or high flow or something, and now they're looking okay. That's your moderate risk patient, is they have lung problems, but you're able to get them back to something reasonable, something greater than 90% saturation. So on these patients, no more of that non-rebreather crap. It's either a formal ventilator or CPAP machine or that lazy person setup with the non-invasive mask. All right, those are your only two choices. Is non-invasive hooked up to a BVM with a PEEP valve with a nasal cannula underneath, or non-invasive mask hooked up to a ventilator or CPAP machine. Head of the bed phase, you just keep them on. Apneic phase, you keep them on, and if you are using the lazy person setup, you just squeeze the bag during the apneic period with a jaw thrust. Laryngoscopy phase, you keep that nasal cannula on, and you now have the benefits of apneic oxygenation. All right, high risk. These are the patients who either you have crappy SATs with augmentation, so they're on high flow or non-invasive and their SATs are still in the toilet, anything less than 90%, or they were in that moderate group, but you look at them and they also have hemodynamic instability, or they also have acidosis, or they also have right heart failure, things like massive PE, all of that stuff. Those, I'd be very scared to paralyze the patients. You want to leave their physiologic milieu as close as possible to what they were at before the intubation. So in these patients, in the preparatory phase, I would say the only option is just put them on a ventilator or CPAP machine. Don't mess around. Have something you could really dial in exactly what the patient's getting. I say plus or minus pulmonary vasodilators. If there's any chance they're going to help, I would add them in. Now, I'm lucky enough to have nitric oxide available. Most EDs are not. Inhaled milrinone through a nebulizer will work very nicely, and every ED should have access to milrinone. And if you want the instructions for that, then just go to MCRIT and search inhaled pulmonary vasodilators, and you'll find the entire protocol for using milrinone. If you can't use milrinone, you could still use nitroglycerin. So everyone has the opportunity for a pulmonary vasodilator. And then plus or minus inopressors. What do I mean by that? If this patient is this tenuous, even a slight drop in their cardiac output is enough to send them over the edge. So I prophylactically augment this patient's cardiac output and blood pressure. So I would have these patients on an epi drip or norepi drip, but preferably epinephrine, even if their blood pressure looks okay. So even if they have a MAP of 65, I'm going to push them up to a MAP of 80 with my epinephrine. And then when they show me they're stable, I could just pull them back and let them drop back down. The intubation is not the time to mess around with just barely enough blood pressure and cardiac output. Head of the bed phase, leave them on, everything. Apneic phase, there is none. There's no apneic phase because we're going to do these patients awake. Awake either with topicalization or with ketamine-facilitated spontaneous breathing intubation, or the combination of the two. But one way or another, I'm not muscle relaxing these patients. Muscle relaxation changes your hemodynamics to the worse, it changes your oxygenation to the worse, and it changes your acidosis to the worst, and it changes your right heart failure to the worst. So in all cases, paralyzing these patients is the wrong move. Just do them awake. All right. And then during the laryngoscopy phase, ideally, high flow nasal cannula will give us our best shot of maintaining them. But if you don't have that, a standard nasal cannula, but I'll open it up to the same rates you'd get with high flow, 40, 50 liters per minute on my flow meters. And Nick Caputo's work demonstrated that is perfectly safe. He did hundreds of patients with that, no nasal disruption, no exploding brains. It's absolutely safe to take a standard nasal cannula and knock it up. All right, so we went through all of that. Why don't we stop there and see if there's any questions?
We do have one question in the chat regarding the nib mask, if it might be sealing badly around a beard or some other complications. How do you augment that?
Yeah, it's a pain in the butt. It's also a pain in the butt for bagging those patients. So, it's a pain in the butt for everyone. One of the solutions is Surgilube. You just douse that beard. You make it like, slick down Vaseline like beard now all of a sudden. Then all of a sudden the seal remains. That because now there's an occlusion through the water saturated Surgilube. Is it the same word, Surgilube, in your countries? The thing you'd use for a rectal exam, that stuff. Yeah, the water-based lubricant. Yeah, that'll actually fix the beards quite nicely.
Instagel glid.
Yeah.
Right.
What else?
There are a few questions, Rasmus, if you want to read them, or Jonas.
I just have a question myself about what respiratory rate you go for if you see 100% during the apneic period.
Yeah, so it's funny. It's such a great question. The amount of minute ventilation you need per minute, right? Minute ventilation is at the alveolar level 250 mLs per minute. At the level of the mouth, we don't want to, discount anatomical dead space and dead space provided by the mask. So we double it, let's say, to 500. And then we always want a buffer of safety. So let's make it 1,000. Let's say you need 1,000 mLs per minute. That's 2 breaths. Anything beyond 2 breaths is going to do nothing for oxygenation. It's going to help ventilation. It's going to stave off the rise in CO2. But, every breath is the potential of insufflation of the patient's stomach. So you want a trade-off. And so for me, that 6, 8, 10 feels just right. I'm getting enough to get the oxygenation, which is 2 breaths. We're getting some blunting of any CO2 rise, but we're not giving us enough breaths to potentially really inflate that gastric area. So if you had a patient on GLP-1s, maybe 2 breaths a minute. Is what I'd give. If you have a patient who is just ate an enormous meal, maybe 2 or 4 breaths. But for most patients, it's 6, 8, or 10 breaths.
We have another question in the chat here. If the patient is delirious or combative, how do you battle that? You're a fan of ketamine in those cases, isn't it?
Yeah, we actually published a study specifically on this, and we got to name something in the literature, myself and my colleagues, called delayed sequence intubation, where if they're giving you any problem at all with what you want to do before intubation to set them up for a perfect physiologic intubation, then you just don't mess with them. You don't argue. I don't argue with patients. I argue with medication. So you push the ketamine, and very low doses. In that study, 0.5 was enough to completely chill out most of the patients in the study. So 0.5 milligrams per kilogram. And that's the racemic form we have. I don't know if the dose, you guys have the enantiomers, so it might be a slightly different dosing. But the point is, you give them enough that they stop resisting, that they become dissociated. And at that point, you can do anything you want.
There were a couple of questions put in the Q&A as well. Some question about angioedema in these cases and facial trauma as well, when it's difficult to mask them during that. How do you manage those patients in event of intubation?
Yeah, there's patients that are just not going to let you do what you want to do. Now, one option is that you can give these patients ketamine and place in a laryngeal mask airway, and then that becomes your surrogate of a mask. And you absolutely could then bag them up, preoxygenate them, do whatever you need. And then you have an option at that point, especially if they're hemodynamically unstable. You could just run a fiber optic bronch, or a video bronch is the better term now, and intubate them through that without even having to disrupt their situation. And you could leave them breathing on, you could be providing ventilations through a BVM or a ventilator during that entire process. So that's a nice thing to have in your back pocket for those situations. Now, sometimes, especially in trauma, you don't have time to mess around, and you just have to bite the bullet and, intubate them rapidly. And in those cases, if there's any hemodynamic perturbation, I just don't give the muscle relaxant. I give a very high dose of ketamine, sufficient that I know the patient's dissociated, and then I'll intubate them just with the ketamine on board and know that they're going to continue spontaneously breathing, and therefore I don't have to worry about much in terms of hemodynamic alteration. Versus, you never know what you're going to get when you paralyze a patient. They can have significant shifts. And the sicker they are, the more shift you get from going from negative inspiratory pressure to positive inspiratory pressure. And it can be quite dramatic what happens to those patients, to the point where a patient who was holding on with a map of 50 all of a sudden is coding. And that's not a fun situation.
Another question is around how do you trust the pulse oximeter? I guess you just preoxygenate them as you would, even if it's an unreliable curve.
Well, it's a great question because, and I if you haven't truly understood this, you could be sent in a wrong direction. So a pulse ox number that's low is an oxygenation issue, as long as the waveform is good. A pulse ox that just isn't reading very well is almost always a cardiac output issue, not an oxygenation issue. And you really have to separate these in your mind. So if you show me a great waveform and they're satting 62%, that's a lung problem that I have to fix. If you show me, they're satting 81, now it's 86, now it's 79, and the waveform is like flat, or it's just this weird kind of, messed up thing, their oxygenation is probably fine. What's the problem is their cardiac output is horrible. And those patients, your first move should be to push some epinephrine. Push dose, not, cardiac arrest dose, push dose epinephrine, in the 10 to 20 microgram range. And oftentimes you'll see their pulse ox improves dramatically, and the number goes from 79 to 98 because they never had a real oxygenation issue in the first place. They have a perfusion issue to their finger. Now, the other nice thing is having forehead pulse oximetry gets you a more central reading than the periphery, and even in the patients who are a little hemodynamically perturbed, you will still get that nice waveform.
And we have an advanced question. I'll just read exactly what Emre writes here. You mentioned that shunt is the primary underlying problem. In your opinion, how appropriate would it be to use the alveolar arterial oxygen gradient before the preoxygenation phase as an indicator of the degree of the shunt and as a criterion for initiating ventilator support?
Okay, let's pretend that this was an optional thing. Then maybe, I think it's still too much work for like the actual mindset you should be in. But I told you, you should be doing this even if the patient has no shunt, because you're inducing shunt by what you're doing, regardless. So then there's no reason. It obviates the necessity of doing a calculation, because you should just assume even if the patient has no shunt now, they will develop it if I don't augment their mean airway pressure. So you should just do this on everyone. And now I've given you a way where you still don't have to get a machine to the bedside before you intubate. There's no reason not to do it on anyone. Let's think about the actual barriers. No matter what, whether you believe me or not, you need to stock non-invasive masks in your department, because there will be sick patients that you will definitively have shunt before you start. So you want to have those masks there. Once you do that, then the next thing is you need to stock PEEP valves. Now, if you're not already stocking PEEP valves, you're really putting your patient in a dangerous condition, because you'll have patients who are requiring 16, 18 of PEEP on their ventilator, and then you go to transport them to CT scan, and if you bag them with a BVM without a PEEP valve, they will die sometimes. We've had it happen in our hospital. I've M&M'd it. I've gone and begged respiratory to never, ever, ever, anyone on greater than 5 of PEEP to never bag them without a PEEP valve on their BVM. And as a result, you'll have a few patients die, and then all of a sudden people start doing the right thing. Learn from the experience of other hospitals. Don't make it an M&M at your shop. So if you're not stocking PEEP valves and they're not readily available, you got to stock them. But I'd say go a step further and set up your resuscitation rooms so that before a patient even arrives, there is a BVM that someone has taken out of the package and expanded, because a lot of them come in a compact form for shipping because it takes up less room. And that's another step you have to do. So have someone expand the BVM, put on the mask, put on a PEEP valve, set that PEEP valve to 5, put it back in its bag so it stays clean with the oxygen tubing hanging out, and plug the oxygen tubing into an oxygen flow meter, and then hang the BVM in its bag on that oxygen flow meter. Now you have what we call a resus-ready resus room. Because now if a patient crash is rolled in somewhere else in the department, they decompensated, and you need to bag that patient, you don't need to set it up. It's just there, and you take it and you turn on the flow meter and you start bagging the patient. That's how it should be in emergency medicine.
All right. I think it's time to move on. We have a few more questions, but we'll just take them later. Yeah.
Oh, so yeah, I think we could probably stop there in the presentation and just stick with questions. I think to add anything would be to subtract from what I've already given you.
Okay, fair enough. All right, so how do you think about intrathoracic pressure and hemodynamic compromise with given positive pressure ventilation in patient with obstructive shock?
Yeah, such a good question. So the thing is that we have to separate out two kinds of intrathoracic pressure. There's the high spikes we get during actual bagging of the patient, right? And then there's the baseline mean airway pressure, the PEEP. Now, if they have bad lungs, that PEEP does not get transmitted to any significant effect, because you're just matching the external pressure on the alveoli with the internal pressure of the PEEP. And it's not until you have your PEEP overwhelming the external pressure on the alveoli. The perfect example of this is the morbidly obese patient. Those folks have enormous amounts of shunt. And it might require, in many cases, 15, 16 of PEEP to get them to what is in essence zero, what we call ZEEP, zero PEEP. You have to put them on 15 of PEEP. That 15 of PEEP in those patients will have no hemodynamic consequence at all because they're not actually having any significant increased mean airway pressure. You're just bringing them to zero. You're counteracting the external alveolar pressure. So when I put a patient on 5, 10 of PEEP, they're seeing very little hemodynamic consequence from that. So if you're giving them just what they need rather than over PEEPing them, the hemodynamics will not be there. Now, the right heart, which is what's taking the hemodynamic brunt of that PEEP, is actually markedly hurt by hypoxemia, far worse than whatever augmentation of interthoracic pressure that PEEP provides. So in every way, PEEP is not going to have hemodynamic consequences. Now, the breaths might, that pressure is usually sufficient, but they're so brief and so sparse, that's why we're not bagging the patient 30 times a minute, that they also will have very little hemodynamic consequence. So in the overall, the provision of this increased mean airway pressure and the provision of those brief breaths during the apneic period, the benefits far outweigh any potential downside from the hemodynamic standpoint.
Brilliant. And speaking about the morbidly obese patients, I usually ramp them at the semi-recumbent position, but then I had a colleague saying that the physiology of the respiratory physiology, at least, improves slightly with the supine position. Do you...
I've never, the last part of my lecture I was going to talk about was positioning, but I think, again, it would steal some of the stuff we've already hit. But just to briefly mention, I've never seen anything that shows supine benefits. Now, where the literature lives is a argument about whether 30-degree head up, exactly what you described, Rasmus, is definitively beneficial or not. But I've never seen anything that says it's deleterious. Now, what we think it benefits on definitively is pulmonary physiology, is in terms of decreasing the amount of shunt and basilar atelectasis. Where the debate lies is whether it improves your laryngoscopic view. But it doesn't hurt. Now, where it does hurt a little bit is getting the patient's face exactly where you want. The higher you tilt them up, the less you could have their face parallel to the ceiling. So 20 or 30 degrees seems like a very nice balance. The key on a morbidly obese patient that people forget is you need an enormous amount of padding underneath their head to get to the point where their external auditory meatus is on the same horizontal line or above their sternal line. The sternal line is the imaginary line from your xiphoid process through your manubrium. And that line, unless you have, it takes me about 30 bed sheets stacked under the patient's head in many obese patients to get them that high. As soon as you do that, Rich Levitan's work would tell us that those patients are as easy to intubate as weight match controls. If you don't get that head up that high, these patients are nearly impossible to intubate without fiber optic augmentation.
I have another question about the ketamine and the possibility of a laryngospasm in adult patients. I haven't seen that, but maybe.
Yeah, I agree. It's very infrequent, like case reportable in adult patients to actually have a laryngospasm in adults. In kids, it happens. Now, what you will see incredibly commonly, and I think this is why people have given this bad name to ketamine-inducing laryngospasm, is for whatever reason, if you give ketamine to do a spontaneous breathing intubation without the topicalization, their cords close between breaths, completely occlude between breaths. And it's very scary to people that aren't used to this. And then when the patient takes a breath, the cord's fully open and then slams shut again when the breath's done. And that's not laryngospasm. Laryngospasm is this continuous spasmodic movement of those cords, and they never open, even when the patient breathes. That's what laryngospasm is. What I've described, what you need to do if you have never dealt with it before, is you need to get either your video bronchoscope or your bougie or your endotracheal tube right in front of those cords, and then you got to wait for a breath. Now, the problem is that ketamine steals their unnecessary tachypnea. So sometimes it's a long time between a breath. It might be 5 seconds before they actually open their cords, but 5 seconds when you're intubating feels like an hour. So people get very scared. But if you wait them out, the cords open and then you just pop through. You could obviate that problem by doing even a little bit of topicalization in addition to the ketamine, which is why I think it's so important that everyone learns awake topicalization techniques. Because even when I'm doing ketamine augmented spontaneous breathing intubation, I still spray their cords with 4% lidocaine. And I found anecdotally that takes away the issue.
Yeah, I'm just going to jump in now, Scott. I just wanted to introduce you to our chairperson for Swedish Society of Emergency Medicine, Frida Meyer here.
Hey, Frida.
Hi. Thank you so much, Scott, for giving this talk tonight. It has been a pleasure listening to you. And this session fits very well into the critical care project that our society is now working with to increase the competence and also the willingness to do this because we are starting. So thank you very much. And if you ever want to come to Sweden, we host our Congress every spring. So if you want to come to Sweden, spring 2027, you're very welcome.
Thank you. That is a wonderful offer and one I will have to take you up on at some point.
Yeah, we'll see. As we said, we have a couple of technical questions still. We'll just save them for a minute. I just want to touch on where Swedish emergency medicine is at this point. We're sort of progressing still 20 years in from the very first start, and then sort of 10 years in since the proper sort of start of our implementing our specialty. And in terms of critical care, we're lagging behind. So we're really making an effort as a society now to go forward in that. Do you have any specific? I know it's a long time ago since the US made the same journey, but do you have any sort of thoughts on how to progressively own not only perhaps the airway, but the critically ill patient?
Yeah, I have found, because when I first started my career, even though emergency medicine had been prevalent for, decades, critical care was not an ED thing. In fact, emergency medicine at that point was built on the idea that since the ICU would take the patient up very quickly in the next 20 to 30 minutes after arrival, you didn't need to do critical care in the emergency department. And that might have been true at some point, but even by the time I started, that was not the case. There were no ICU beds available, so patients would languish for hours and then, as the years progressed, days in the emergency department. So the real answer is, if patients really are going up very quickly, then, it might not be a fight worth fighting. And then you have to just become incredibly good at resuscitation, the first, 1 hour, 2 hours of the patient. Now, as soon as the ICUs start becoming burdened, and it might be the case already, if patients are spending hours in your department, then it's a clear path to say, these patients deserve the exact same care they're going to get upstairs, if not better. And therefore, we need to be providers of critical care as well as standard emergency medicine. And then you start taking ownership of it. And you start having the other specialties teach you the way they do it so that they have a sense of trust and a sense of continuity. And you do it their way for a little while. And then once they've relaxed their suspicions, then you start doing it your way. And oftentimes your way might even be better than they do it upstairs. But you start with their way so that there's not a fight. It's like, oh, you're doing it this way upstairs? We want to be able to do that downstairs. Come teach our nurses. Come teach our nurses how to do it the way you guys do it upstairs. And then they start developing a sense of safety. And then you own it. And they don't want it back because they're very happy to not have to leave their ICU and come downstairs and resuscitate patients. They want this eventually. Now, once that trust is there, then you start expanding. And it just becomes a very happy situation. Unless you have the evils of territory and academic silos. And this is what we had to fight in emergency medicine, is anesthesiologists telling us ED can't intubate, right? Not because of any real reason, because the studies are very clear. We're just as good as anesthesia. Every time they put head-to-head ED and anesthesia, EDs do just as well. It becomes just a intubation equals an anesthesiologist. And those kind of fights, you just have to gently explain that the literature is not there to support it. The rationale is not there to support it. So we really have to move beyond territoriality and silos. And eventually, if you persist, they give up because they don't, it's just such a silly argument for them to persist on. And every country that's wanted it has eventually won.
Yeah, and I mean, you can take the example of all the other specialties that we in turn sort of had the same type of conflict for. I mean, in Iceland, cardiology persisted in seeing their every chest pain patient until they got badly staffed and handed it all over, and obviously never wanted it back. So it's the same type of story, but it's just one really rough and persistent conflict that we've had over time in Sweden at the moment.
Absolutely.
Yeah.
But just persist with love, right? Like, you don't want to be strident, you don't want to be mean, but you don't want to give up any ground with the fact that emergency medicine owns resuscitation and critical care in the emergency department. That's what we were built for, and that's what we need to do. And we become, rather than some kind of theoretical specialty, a geography-based specialty. We need to be the experts at everything that happens within the auspices of an emergency department.
I think we're nearing our hour here. Mohammed, do you want to sort of round things up?
Yeah, exactly. It was a really, really amazing webinar with you, Scott. It's really, you made a very nice Friday or week for us. We finish our week with you, and we really, really appreciate to have you next year with us in our conferences, just to receive more from your knowledge. And we want to see you more in the future and collaborate with us.
It's always a pleasure. It was so much fun, and thank you for having me.
And for everyone
Thank you
coming
very
to
much.
Spain in a couple of weeks, we'll see you there as well, Scott.
All right, can't wait.
Exactly. See you in April. Thank you. Bye.
Bye-bye.
See you there. Bye.
Thanks, everyone.
Thank you, everyone. Take care. Bye.